Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. I'm your host, Dr. Kevin Hopkins, a family medicine physician and senior physician advisor here at the AMA. There are a number of reasons why medical school can be incredibly challenging. Between memorizing and retaining massive quantities of information, rotating between multiple different clinical specialties, high academic expectations, both externally and internally, not to mention the cost and the reality of the subsequent student debt. The reality of an experience in medical education for most of us is that it can be overwhelming, even to the most ambitious and level-headed students and residents. Here with me is our guest to discuss how to reduce and mitigate risk of burnout and promote well-being for medical students and residents is Dr. Laura Vater, a gastrointestinal oncologist at the Indiana University Simon Comprehensive Cancer Center and assistant professor of clinical medicine at the Indiana University School of Medicine. Thank you for being here with us today, Dr. Vater.
Thank you, Dr. Hopkins. I'm thrilled to be here.
Wonderful. Before we get into our topic of conversation for the day, Laura, would you mind telling our listeners a little bit more about yourself and your background than what I was able to describe in the intro?
Wonderful. Yes, I am a medical oncologist here in Indianapolis at the IU School of Medicine at the Simon Comprehensive Cancer Center. I'm also heavily involved with learners across the nation, thankfully through social media. I have a community of about 200,000 people, primarily clinicians, medical students, and residents. And I'm also a writer. I write both in the realms of narrative medicine and fiction.
Awesome. Thank you. What really interested you in getting involved in this work related to wellness and well-being, and maybe specifically in terms of learners, medical students, and residents?
Yes, I think like most of us that come to the well-being space and promoting clinician well-being, we come to it from our own personal experiences. When I was a kid, my mom went to medical school when I was 9, and I watched her go through medical school and then through a residency in internal medicine. And then I've subsequently, as a teenager, watched her practice primary care in a rural, underserved area. So from a very young age, I got to see the challenges, the wonderful things, the meaningful aspects, but also the challenges of practicing medicine in the modern era, of seeing more patients than you may have capacity for, of bringing work home, of being on call, of dealing with some of the losses in medicine, witnessing illness and trauma and death. I witnessed many of those things from a very young age. I also had a keen interest in medicine as a kid. My mom jokes that I was interested in medicine before she was, but I ended up, following along that path. I went into medical school. My mental health going into medical school was, on par with, just like we know, people that come into medical school typically have excellent mental health. They're highly altruistic people. And, in my very first semester of medical school and kind of thereon for my first 2 years, I was experiencing anxiety really for the first time in my life, to the point of even having panic attacks, of really studying sometimes 18 to 20 hours a day because I thought that's what it needed. I was not sleeping by choice. And that very early on influenced kind of this, that I thought, wow, something's wrong with me. I must be defective or weak or not good enough. Only later did I learn that about half of medical students experience anxiety, even if they've never had that before. And only later did I find that peers in my same cohort or my same class were experiencing the same things. But of course, we don't talk about them. We often experience them in isolation. Then as a resident in internal medicine, in my second year, I had about 5 months of really fractured sleep through different rotations, working in the ICU, working nights, working on the wards, but being on call, followed by nights again. And I started to experience passive suicidal ideation, right? And then unfortunately, this began to grow. And I saw this pattern of that when I was rested, my mental health felt normal. And then when I was sleep deprived, usually awake 28 or 30 hours, I would feel this desire. I remember sitting very clearly, I remember sitting in the parking lot after a long shift in the ICU. Not only had we had multiple patient deaths, but I was just physically exhausted. This had been kind of a marathon I'd been running for a long time. And I remember sitting there and thinking, I don't care if I make it home alive. And then really, without going into any details that might be triggering for any of our listeners here, began to create a plan. And this was very distressing for me because this really took me by surprise. I'd never experienced anything like this before. And so I started journaling. I've always been a big writer, a big journaler, to really process. We can get more into that, witnessing what we see in our field, but really finding these patterns that when I was rested, I seemed to be okay, but when I was sleep deprived, clearly something was wrong. And I was scared to seek help. I was at this place where I was applying for fellowship. I was terrified that if I were to seek help, that it would have professional consequences for me as a physician. So I didn't. I just, like most doctors do, especially doctors in training, whether that's medical students or residents, we just grit our teeth and try our best to get through on our own in isolation until an easier month finally came. And it felt like I was coming up for air after being trapped underwater, is really what that felt like. And looking back, I wish so badly that I had sought professional support. I now have a therapist. I'm very open about mental health. We have created a number of interventions on our campus, and thankfully other programs are doing the same to help better protect the sleep of resident physicians and clinicians, and to provide things like opt-out counseling where you're just automatically enrolled. But that has really been how I became an advocate and really began to immerse myself in this topic, not just the research, but then also mentoring others and having others reach out to me who are going through similar things online.
Thank you so much for sharing. And I know that's just the tip of the iceberg. And it made me think, Laura, that while your personal and individual experience in training was certainly unique to you, it was not altogether uncommon. And as we start to talk about these things, right, we find that so many other folks have gone through very similar situations, circumstances, as you said, really in isolation. And none of us do well or succeed in isolation. We were created for relationship. And so relationship is at the most basic core of the human psyche. And so it's powerfully beneficial to us. And you made so many good points in that statement. Thank you. Thinking about resilience of medical students, right? The research shows that when we come into medical school, most of us have higher personal resilience than our peers, than most people that go into other professionals. And yet after the first 2 years of medical school, that difference in our superior resilience capability actually erodes. And there's something that I think has to do with the educational process, the medical education process, that does that to people who are by nature high performers, overachievers, filled with ambition and willing to delay gratification for something bigger than themselves. I also found it really interesting that you talked about that you did better when you were rested and things didn't go as well in your mind when you were sleep deprived. Can you talk a little bit more about that? I heard you talk about the hours of studying, and certainly that's not something that's unfamiliar to all of us. But what led you to realize, oh boy, sleep is a real key for me?
Certainly, I noticed these patterns in myself, and then I really came to the data, came to the evidence. There's a great book by Dr. Matthew Walker called Why We Sleep, and that's really the first thing that I came to. That book, among many other research trials I've come to, have proven without a doubt that sleep deprivation is an independent risk factor for anxiety, depression, and suicide. Our minds do not work well without sleep. We evolved to need sleep despite the vulnerability that it provides. You are asleep in this vulnerable state where you could, of course, be attacked, right? You could be using that time to find water or food or to protect yourself, but yet we need sleep, and it is an essential component of our functioning. That's true for our cognitive functioning. We know that without sleep, our physical coordination is impaired, our cognition is impaired, we're more likely to make mistakes. We cannot have as much memory recall. Our learning is actually impaired when we are not when we do not have good sleep. We also know it affects our physical health. We're at higher risk for cardiovascular disease, stroke, diabetes, weight gain, even cancer. And of course, it affects our mental health. There have even been some studies that have come out recently that after 24 hours awake, we have lower levels of empathy. And if you look on MRI scans of the brain when it's sleep deprived, there's far less activity in the empathy areas of the brain. We know that doctors who are low on sleep are less likely to have high levels of empathy and are less likely to prescribe medication to help comfort a patient. And so some of that data is very clear, but what became very interesting to me is that we don't really talk about this data. This data exists, but we don't talk about it. We are in a very unique and unusual field where we are many times expected to practice medicine while we are sleep deprived. And sometimes a surgery takes 16 hours to perform, and I understand that sometimes there's no way around that. But oftentimes, and we can talk more about this through medical education and training and even practice, physicians and other clinicians are in situations where they're working in a sleep-deprived state, and that does affect patient safety, but it also truly affects the well-being of clinicians. We don't expect pilots to do this. They have very strict regulations about sleep. Truck drivers have very strict regulations about sleep, but yet the medical field has not yet really caught on to this evidence-based data, and I think that's very interesting to me.
Right. And certainly there have been advances and movements in that way. I was in residency, I think my third and final year of my family medicine residency when some of the resident work hour restrictions came to be. But, before that, it was sort of like there was work that needed to be done and we needed to do it. And you're right. We talk about the potential consequences to patient quality and safety, but not as much about the consequences that we experience as the medical professionals who are living it.
Certainly. And I think the other interesting component that I was not fully aware of was that, thankfully, where I trained, it was very strict. You do not work more than 80 hours. And if you are reporting more than that, we need to fix a problem that's happening with a certain rotation. But I will tell you that I have had hundreds of residents across the nation reach out to me over the last 5 years saying, yes, we report 80 hours, but we work 100 hours. We work way more than we are expected to report. And then the other challenges is home call, right? So home call is a situation where you can work all day and you're at home, but you may get called every 20 or 30 minutes all night. And that time doesn't really count. That happens in residency still today and primarily in fellowships as well. So you're looking at trainees who are awake sometimes for 72 hours. They may have had maybe a couple hours of sleep within 72 hours on a long weekend home call. It's oftentimes week at a time, right? So you're talking hundreds of hours, 100 hours maybe without quality sleep or really any sleep, depending on your specialty. Residents that have gone into psychosis, that are seeing visual hallucinations, that are getting in car crashes and dying. So I do agree that there have been significant changes that have happened, unfortunately, with what happened with the Libby Zion case, the changes of work hour restrictions, first in New York, then across the country. And we have made significant progress. And there are a lot of really good people in medical education and program directors across the nation who really care about their resident well-being. And some of them know that their residents are working more than they actually are, and some of them don't. I think there are good people in this field, but I still think that there's a lot of work to be done.
You mentioned that even throughout the course of your training, you had concerns about the professional consequences or potential professional consequences of seeking help. And certainly that's a common topic for discussion today. You think of the work of the Lorna Breen Foundation and certainly our AMA and many others to sort of destigmatize mental health and mental well-being and remove barriers to medical professionals getting help when they need it. What concerned you or what caused you to be concerned about potential professional consequences of seeking help even at that stage of your training?
I think part of me was worried that I might be forced to take a clinical pause, right? That I may have been seen as, okay, something's going on. And in a good way, it probably would have been helpful for me to say, okay, I just need a week or two to just sleep and recover and then jump back in, enthused about my work, excited to be there and better rested. So I think part of my fear was if I had to take a clinical break, would that interfere with graduating on time, and would it interfere with my this all was happening about a month before I hit the submit button for fellowship. And I had all of these months of easier rotations coming where I was going to go interview at all these programs across the nation. So part of me was worried, first of all, would that show up on my application for fellowship that I had this 1 or 2 week? It probably wouldn't have. The other piece of this was, what would my program think of me? I really prided myself in never missing a day. I never missed a day of residency. I worked even when I was sick. I had a young child. I never left early or took a day. And I really prided myself on that. And I think as a mother in medicine, right, I tried to keep myself to a higher standard because of that. And I think there was some pride involved and some shame. Everyone around me seems to be doing fine with this same schedule. What's wrong with me that I can't cope? And so I think it was all of those things. And I also don't know if I physically had the energy or the know-how to really seek the help. And if I'd had to physically go somewhere for a 2-hour meeting, that just sometimes when you're in that place, even small things that are extra things can just feel overwhelming.
Totally resonates with me. And I've heard you use the phrase in the past, speaking about challenges shrouded in shame. And I've heard other people use the word shame to talk about how it makes them feel. To some extent, like I've experienced that myself. I had a time where my doctor told me, you need to be off work for an extended period of time. And I have to admit, that was really tough for me because I had to sort of confess or accept that I could not do my job and my life successfully at the same time. And that is extremely humbling. And like you said, can cause a sense of shame. I want to pivot now and get to some of the interventions. Are you able to talk about maybe some interventions that have been successful, either that you've seen on a broad scale or specifically at your program at Indiana University?
Certainly. So a few things that we have done to improve well-being at our institution has been really looking at call structures for resident doctors, and are long shifts essential? Now, I understand that I am not a surgeon, and I understand that there are unique challenges that surgeons face in terms of long operations and whatnot. But for more medicine-based specialties, especially here at our institution, in our internal medicine program, we've been able to do away with a lot of those 28-hour calls and have really good sign-outs, and to adopt more of a night shift rotation for many of those, and to do it safely. That has been one thing that's been able to better protect the sleep of residents. In our fellowship, in our hematology oncology fellowship here at IU, we did away with home call that required overnight coverage of a bone marrow transplant unit, which is an ICU. So we did that for a week straight. And sometimes we would get calls for a week straight every 20 or 30 minutes. Maybe you'd get 45 minutes or an hour, but it was a very busy service with a lot of calls of giving a person potassium, or they need a blood transfusion, things that didn't necessarily need a hematologist oncologist. So we were able to hire a nocturnist to cover those shifts. That took a long time. And of course, all of these things, especially many of them, are staffing issues and budgetary things. And those things can be very challenging for training programs. But thankfully, those have been two big successes, and they take time. Those things really take time, and leaders who work very hard to push those things through. And so kudos to our program leaders who have done those things. We've also added what's called an opt-out counseling option for our residents. That is something that basically residents are just automatically enrolled in counseling. They have set appointments, right, that they do in advance, and it just normalizes it that, oh, it's 2:00 on a Tuesday, and it's my time. I just go this month, and this is where I meet with my counselor, and then we check in, and have I witnessed trauma or illness or death? Do I have personal relationship things, financial strains, anxieties about applying to the next level of my career? So you can talk about anything, but it's meant to be more of a structure that's in place, especially if something worse were to happen, it's already in place. And I think all of us that take care of patients, whether those are children or adults that are dealing with really hard things, and we're witnessing devastating things on a daily basis. Even to my day now, as a gastrointestinal oncologist, I care for most of my patients have stage 4 pancreatic, gastric, or colorectal cancer. And so 80% of my patients, unfortunately, do not live for 5 years. And so a big part of what I do is end of life care. And there's a lot of grief around that. I think all clinicians would benefit from some type of therapy. So we've been able to include that in residency programs, and hopefully that will normalize it so that they might be willing to continue that past training.
All right. And I know that you've said, I heard you said just a few moments ago in our conversation that even in your experience in training, journaling was a very powerful tool for you to use. And obviously you enjoy writing, you find it fulfilling personally and professionally, and have had a lot of success in that area. Could you talk maybe about what your experience was like using writing as an outlet to help manage stress and to help prevent and mitigate burnout? And have you seen that be successful for others, either formally or informally?
For me, I started journaling as a medical student out of necessity. So when I was a third year medical student, I was pregnant by choice. I was a non-traditional medical student, had come to the field late, and we were ready to have a child. And so I was pregnant and I was rotating through high risk maternal fetal medicine. And it was really hard. We saw a lot of very ill mothers and a lot of babies that passed, and that was hard for me. And I remember one specific family that had lost their child. It was a stillborn child, and the child was the same gestational age that I was pregnant. And I was witnessing this as a medical student. So there I was in my scrubs and my short white coat, the passive observer, right? Kind of in the back of the room. And I couldn't help think about this family. Had they, painted the nursery room? Had they picked out a crib? This life that they had hoped for and planned for, and just the devastation of grief of that loss. And then, of course, I witnessed that ritual of loss with the nurses as well, of, pressing that foot into ink and onto paper. And it was a very emotional experience for me because of what I personally was going through. And so I remember walking out at 2 a.m. and it was February cold, and I just burst into tears. I'd kept it, I'd held it together the whole time, but then I no longer was this medical student. I was this mother, right? I was this pregnant mother. And I just was driving home and just crying for this family. And of course, there's no way that I couldn't feel something because of that patient reminded me so much of something personal. And that's when I started the next day. I said, this has to go somewhere. Where is this going to go? It has to go somewhere. I later came across this idea that Dr. Rita Sharon, who of course is really the founder of narrative medicine and who's at Columbia, and this idea of what's called the parallel chart, meaning that certain patients may remind you of your brother or your mother or a loved one or your best friend, and they're going to evoke emotions in you that may not happen with other patients, and those need to go somewhere. They can't go on the medical chart. They need to go somewhere. And so there's this idea of the parallel chart, which is this HIPAA compliant journal, whether that's electronic or personal. It can't have any patient identifiers and nothing that could be violating privacy of a patient, but a way for you as a clinician to process what you're going through. And so I started this as a medical student and really continued it through residency. And it wasn't until the very end of my residency that I was doing all this writing that one of my mentors said, Laura, you do all this writing. You should probably try to publish some of these as narrative medicine pieces. And so I was like, oh, okay. So that wasn't my intention when I started, but then I kind of went back and I had a mentor that said, we have shared experiences in medicine. There are other people that may benefit from your sharing and processing of something that's very difficult. It might help them to either cope, feel less alone, or process through something and help them heal. And so the first essay I ever published was the essay about being a pregnant medical student witnessing that stillborn child. And I titled that Papaya because that was the gestational fruit of the size of my daughter was the size of a papaya at that season of life. And I've gone on to publish other essays about loss and through the COVID pandemic of what that was like, was I going to bring this virus home and give it to my young child? A lot of these things that we, mental health and seeking help it's helped me to process those experiences, but I've had people reach out to me and say that it has helped them feel less alone and has helped them to heal as well. And so I continue to write personally. And then, of course, through narrative essays, we have created a program on campus for our Department of Medicine that is called Writing for Wellness, which is coming together monthly. And we read an essay together, and then we have a writing prompt, and we have free writing time. We invite people to share if they'd like to, but sometimes people just share their own experience. So it creates a community, it allows vulnerability and hopefully healing.
What have you seen or heard as some of the most common or key stressors for learners today in medical education?
Many learners express a feeling of overwhelm, not just to go to lecture, but then also to score as well as possible, depending on their specialty of choice, right? So there's a lot of stress to ingest a lot of material very quickly, and are they choosing the right material? Because there are so many options that are for board review, specifically for the STEP exams, that sometimes may not always align with what they're learning in the classroom. And so that challenge of what do they study? How much do they study? Of course, there's the challenge of how do you have any time for your health while you're doing all of this? How much should you sleep? Should you take time to exercise? What about your social relationships? Many of them feel like they kind of need to neglect every other area of their life so that they can succeed, particularly if they feel that they want to go into an area that is particularly competitive. And then, of course, just like you mentioned, I think that there's a number of other challenges that align with that. Sometimes they may experience harassment, bullying, or discrimination. I think that's getting better, but unfortunately that does still happen, and many people do reach out to me with those experiences. There's a lot of imposter syndrome of feeling like everyone around me seems to know what's going on, and I feel inadequate. I'm not smart enough to be here. I'm not good enough to be here. I'm never going to cut it. And then there's this witnessing, like your first code blue. The first time that someone is describing a terminal, prognosis, you're in the ER and you're working a trauma shift, and you see a terrible car accident, right? Or you see a gunshot wound, or you see child abuse, right? And I think that there's a lot of trauma and challenge that comes with witnessing those things, not just for the first time, but repetitively. And we as clinicians, I think about this a lot, right? My emotional reactivity has lessened over time. I think for all of us, it has to. We find ways to cope and process through our emotions in the time being so that we can be objective and continue to function in our role. But that does not mean that we as attending physicians don't have feelings for our patients, that we don't care, but we have different ways of processing through those. But I think oftentimes medical students see me as the gastrointestinal oncologist go in, and it's a hard conversation. A person didn't think they had stage 4 gastric cancer, and they actually do, and they're screaming and there's crying and there's like tons of emotions and support and planning and next steps. And they're just crying in the room, and I support them. I say, tears are a sign that you care. Of course, we never want to be the neediest person in the room. A patient should not be comforting us, but I tried to tell them, I walk out of a hard conversation just simply as an attending saying, that was really difficult. Oh, that was devastating. I think it can be helpful to normalize that, and to even when you see a learner, oftentimes learners can be shamed for having feelings or expressing feelings, and really they are often seeing something for the first time, and they're a human being. And so I just try to remind them, hey, you're a human, and that means that you care, and you are an altruistic human being who's entered into this field. And so I do think that is one challenge that they face is not all medical students, but many of them, that they're seeing these kind of stoic, seasoned doctors and, seemingly unfeeling when I don't think they really are, but now on the other side of things that they may not quite know how to process through these in a healthy way. So I think that's another challenge. And of course, there's the financial piece, which is huge. Undergrad debt, sometimes debt just for their own living, maybe a master's degree, and then medical school, and then just trying to fund their life through training. How do they plan to, are they going to get married? Are they going to have a kid? There's infertility involved. So, there's lots of other personal challenges that those in the medical field face that others, perhaps outside the medical field, may not face to the same degree.
Some great perspective for us all to think about. And I particularly love the tip of, you're right. We can seem relatively desensitized to people who are more junior in their career path. And so even just verbalizing, wow, that was hard as an attending physician. And like you said, normalizing it, I think can be very powerful because you're right. They may not see us have the same emotional response. We may be having it on the inside, but they may not see it. And I always think if I ever lose that humanity completely, it's time to hang it up, right? Because I've really lost my ability to connect with my patients on a human level. I want to get to one other thing here. During your own medical training, you created something that was a tool for yourself, really, but you've shared it and that you called the SMILE scale, a wellness-centered behavioral tool designed to measure and encourage our own healthy habits. Can you tell us more about what led you to develop that even for your own use and what it represents?
Certainly. So I have a background in public health, which is very focused on prevention and healthy behavior promotion. And then in my training, of course, I was studying for these boards and learning all of those mnemonics, right? You're learning about, okay, these are encapsulated bacteria and I'm memorizing this way. And so I had all of these memory tools to remind myself of all these truly arbitrary facts. And I came across a Time magazine had a whole section on happiness, and I happened to pick it up and I took it home, and it was really looking at the science of happiness. So it was around that time that I was a young mom. My daughter was about 1. I was an intern, and I was thinking, oh my goodness, I know that these healthy behaviors are important. Things like sleep and exercise and, eating a plant-based diet, all of these things. So I just devoured that science, and then I dug into it more. I read hundreds of articles about longevity and happiness and overall health and, lifestyle medicine. And I thought, okay, I need to create a tool for myself so that when I'm in the midst of all of this training, it can be a gentle tool for my memory, to jog my memory, to remind me of the things I need to do to promote my health. And of course, I've used that tool on a daily basis really since that time to help nudge me in the right direction. I also know that this is not a cure-all for clinician burnout, right? Focusing on individualized behaviors, right? Of course, we are already highly resilient people. We have this knowledge of the behaviors that protect us. It's often our environments that affect our well-being more than anything. But this tool, I invite anyone who's listening to join me in it. We're going to ask 5 simple questions about our health today. And it's going to be each letter of the word SMILE is one question. So S is sleep. Have I had at least 7 to 9 hours of sleep in the last 24 hours? You answer that yes or no. If it's yes, give yourself 1 point. Then it's M, move my body. Have I been physically active for 30 minutes or more? Again, if it's yes, give yourself 1 point. I is inhale and exhale. Have I found healthy ways to reduce my stress today? That might be, I'm a big meditator. I've come to that kind of as a tool. So is it meditation, deep breathing? Is it walking in nature? Maybe it's listening to music or reading a book or prayer. Whatever that healthy thing is for you, have you done that ideally for at least 10 minutes today? L is love and connect. Have I meaningfully connected with another person today? And if yes, give yourself 1 point. We know that our social connections are very important for health, particularly our closest 1 to 3 people, whether that's a partner or a friend or a parent. And then E is eat to nourish. Have I eaten at least 5 fruits and vegetables today? If that answer is yes, give yourself 1 point. And you kind of tally your score. It can range anywhere from a 0 to a 5. Some days I'd be a 0 or 1, and I'd say, okay, well, this is why I feel terrible today. If it was a 5, 4, or 5, I tended to feel a lot better. And so it wasn't something that I felt guilty over, that I was telling myself, I'm getting terrible scores. It was just something that could help nudge me in the right direction. In my training, I ended up, bringing a lunch bag to work every day. I'd always keep a mug in it with some, maybe some tea or some herbal tea, a jar of nut butter. And then I just throw in whole plants, like a whole bell pepper. I used to eat like an apple, or a whole avocado I'd cut in half with a butter knife and eat with a spoon. And, just ways that I would try to, in a situation that felt very out of control, something that I could try to protect my health. Sleep oftentimes was out of my control with both a young child and being a resident. And then for exercise, when I was on call, I used to set a timer on my phone for 30 minutes. And I'd say, I'm going to do something active for the next 30 minutes. If I get paged, I'm just going to pause it and take care of whatever patient needs to happen. But If I can, I will do some stairs. I'll go for a walk in the hospital or outside, and I'm going to do something that is physically active. So it's been little things that have helped nudge me in the right direction and trying to promote my health as much as I can. And of course, now we've studied this tool, just published it among patients with cancer and a pilot study that it can be protective for patients. And of course, there are other groups, nurses, clinicians, even some middle school students that are using it. So
terrific. So smile, sleep, movement, inhale and exhale, love and connect, and eat and nourish. So a good way to sort of to check in with ourselves to see how we're doing with self-care. And you're right. There's so much that we feel like is beyond and out of our control. And to have some semblance of control over something small in our life can be very meaningful and very empowering. So thanks for sharing that tool with us. Are there any other sort of pearls of wisdom that you'd like to share with us, Laura, that we haven't been able to get to in our conversation yet today?
Absolutely. I encourage anyone in the medical field to seek a therapist. Many people don't feel like they can do that within their healthcare system, but you can always find one that's kind of outside of the healthcare system, outside of that, if you feel more comfortable with that. There's also a free physician suicide support line. It's actually free for medical students as well. And it's actually, volunteer psychologists and psychiatrists who do that. And so that, if you just Google that number, it's freely available. And so there are resources that exist. If you ever feel like for anyone that's listening that may feel like they're in a place where they don't know where to seek support, know that if you have those fears, which I think for me were unfounded, but if you have certain hesitations or fears about seeking support, know that there is also support outside of your institution.
Great. Thank you so much for being our guest today, Laura. It's great to meet you.
Thank you, Kevin. It was great to be here. I really appreciate it.
Dr. Laura Vater, gastrointestinal oncologist at the Indiana University Simon Comprehensive Cancer Center, an assistant professor of clinical medicine at the Indiana University School of Medicine, has been our guest today on the Steps Forward podcast from the AMA. Check out the episode description for more resources, and until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.